So I am very excited for Cassie, one of our very own physician assistants, joining us today and kicking off 2022 to talk with us about key concepts and complications managing cancer-associated thrombosis. So Cassie Frank is a physician assistant working in the Division of Hematology Oncology at UNC since 2016. And most recently focused on iron disorders and thrombosis. She currently leads the DVT Walk-In Clinic in benign hematology and has a special interest in improving patient access to care and education. She enjoys teaching at Elon's Physician Assistant Program and has also guest lectured in hematology at UNC. So welcome, Cassie. Thank you for joining us today. And outside of your professional bio, what's something personal, a hobby you'd like to share that you want our audience to know about you?
Yeah, I mean, I think the most tediously creative thing I do is compete in the annual gingerbread competition around here.
Oh,
it's kind of a big deal. Yes, this year I made a gingerbread Notre Dame. It only came in second to St. Basil's Cathedral. I'm only a little bitter about it. It's fine. There's always next year.
Well, wow, who knew that that was a contest? So thank you for sharing that that's even a contest. So maybe you'll have some competitors out there, but that's a great accomplishment. Congratulations on second place. So throughout our lecture, we will have poll everywhere questions. You can join online at pollev.com/UNCCN. You can also text to UNCCN to 22333. So this is what it'll look like. You can think about your answer. Thrombosis, or the blockage of veins or arteries by blood clots in a cancer patient, can increase the likelihood of mortality. So this is a sample question to get you guys started on working poll everywhere. Our disclosures today: this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Cassie Frank has a financial relationship with Pfizer that has been mitigated. This relationship did not influence the planning or implementation of this activity. So here is our first poll everywhere question. Log in. What do you guys think? True or false? Thrombosis, or the blockage of veins or arteries by blood clots in cancer patients, can increase the likelihood of mortality. We got 100% true. How'd they do, Cassie?
I think that's fair to say, yeah.
Okay, great. All right, Cassie, I turn it over to you.
All right, well, I'm happy to be here. I wish I could see everyone and be in person. If we were in person, you would see that I've got my elbow pads on, which means I'm feeling professorial and ready to teach you some things. I think that thrombosis in any setting is extremely nuanced and takes a very long time to wrap your head around, for me included. Constantly learning new things. There's always something else that could be influencing your decision making. So there's no way to talk comprehensively about everything in cancer-associated thrombosis today, or even, just thrombosis. My goal in the talk is to kind of answer really common questions that I get consulted for, or curbsided for, or phone calls about. A lot of these are going to be nuanced enough decisions that a referral to hematology is beneficial. But if you are in an outpatient clinic or a setting where you don't have specialized benign hematology, hopefully this helps answer some of the bigger questions or unknowns. And so we're going to go through some basics, but mostly cases that illustrate some of the biggest conundrums that come up, or complications and concepts. Next slide. That's just my disclosure with Pfizer. So the objective, first, I think the language is important to understand. So if you're talking to someone about a clot, you know, what are you even describing? Are you using the right words? So to define a clot based on where it's located, being a DVT versus a PE, and kind of what terminology we use, and then how you implement intervention, treatment, and then risk factors. So everything in medicine, as in many things, is risk benefit, right? So when you're talking about anticoagulation, what kind, how long, everything is this constant seesawing of balancing risks of blood thinners and risk of thrombosis. So identifying your risk factors and having a way of doing that helps you wrap your head around all the pros and cons of every decision, I think will help you to rationalize how we choose anticoagulation management, and then also how to discuss these things with your patients. So next slide. So the first thing is defining the blood clot, right? So I think a lot of the time we say, oh, they have a DVT. Oh, okay, well, what does that mean? Classically in school, you're probably taught like, oh yeah, like unilateral, bright red, swollen leg. Yes, that is a DVT. Yes, if you work in an ED, you better be, you know, using your Wells score and things like that, and considering ultrasound and D-dimer. But when we talk about DVT kind of more broadly, you know, they don't all present like that. They can be in multiple different locations, and they are not always, when we use the word deep, you know, sometimes we're using it interchangeably with superficial veins. So just to get the lay of the land, a venous clot can be superficial, so towards the surface of the skin, or it can be deep. The ones in the deep vessels are the ones we're typically more scared of. They've got a bigger lumen. They can be more a bigger clot. And in a lot of cases cause more damage, be more likely to embolize, travel, et cetera, et cetera. So a superficial clot occurs in a superficial vein and is distinctly separate in definition and treatment from a deep vein clot. So that's the first thing you don't want to mess up. If it's superficial, call it a superficial vein thrombosis. If it's a deep vein, call it a DVT. And then within DVTs, you also have all sorts of different nuance, right? So a blood clot that is at or above the knee, we consider proximal, so that's popliteal vein or above. You can see, I wish I had like a pointer. I don't know if you can't see my mouse, but right at the popliteal vein, there you go. Thanks for the assist. Yeah, so the popliteal vein where that circle is, there or above, we're considering that a proximal clot. Below that, we're considering it a distal clot. That matters quite a bit. It matters probably more in non-cancer patients if it's proximal or distal because they're treated quite differently. Cancer patients, as you'll see shortly, are a little bit of a different story because once they've demonstrated the ability to clot or the tendency towards clot, we care a little bit less if it's proximal versus distal. But in general, if you're talking about a clot, you need to be able to say they have a distal DVT, they have a proximal DVT, they have a superficial vein thrombosis. Those are all different things. And as I said, generally duration of treatment and type of treatment is dependent on these definitions. Helpful kind of material along these lines can be found at clotconnect.org. This image was is an illustration by Dr. Stefan Mall, who runs that educational resource, and I highly recommend it. There's pamphlets there, things you can print out, but I use this image with many of my new diagnosis patients to explain what's going on and where. Next slide. So then I think this gets glossed over quite a bit, the difference between an acute and a chronic clot. So an acute clot, we can all kind of picture if you've ever had a nasty bloody nose, you've pulled out a nice big clot. Patients love it when I talk about this, by the way. There's other grosser clots I could bring up, but that's the one I usually use as an example. It's spongy and it can be dissolved, right? So that is the kind of clot that when we give a blood thinner, we are letting your body reabsorb that type of clot, get rid of it. And those can be treated. Chronic clot is really almost a misnomer. It's really a reference to the kind of scarred, chronic residual clot that does not go away. All the blood thinner on the planet is not going to get rid of a chronic clot. It's out of the stage of acuity where you can actually reabsorb it. So determining chronicity is actually quite important because a chronic clot it's just not, it's not going to be treated with an anticoagulant. So if you have an ultrasound that demonstrates chronic clot, number one, it probably hasn't only been there for a couple months. And number two, giving blood thinner probably won't treat it. That does not mean that they won't benefit from blood thinner, but it's for other reasons. So knowing the chronicity is actually really important. It's less straightforward to determine chronicity with a PE. Often PEs stay acute appearing on imaging for a longer period of time. But with Doppler, usually you will get in the Doppler report some sort of indication that a clot is more chronic. And it'll say, you know, imaging that appears, changes that appear long-standing or chronic in nature, things like that. And we could go into the details of what you see on ultrasound, but I won't bore you with that. But suffice it to say, there are differences in the appearance that can help you differentiate. I would always consider both the patient history and the imaging. So if they say, I woke up with this giant swollen red leg and it has never looked like this before, even if imaging suggests there's chronic clot, my assumption would be it's acute on chronic. There's some acute component and you can't really tell the difference. If questions arise, please call radiology, call your Doppler techs. They're really good at what they do. I call them all the time. They recognize my number. It's embarrassing, but it's the best thing for the patient always to get clarification on that. So definitely don't be afraid to ask, how old does this really look to you? Next slide. And then PE. So pulmonary emboli, you know, they're very scary. They're known to cause sudden death in not a small number of cases, but they do also have a range of severity. So how scary are they? Well, we categorize them in three ways. So low risk, meaning the heart has not been impacted. You're not getting that backflow into the right heart that can cause some of the more serious complications. Submassive means there's evidence of right heart strain, but you haven't had hemodynamic compromise. So usually this is indicated by, and I have some imaging examples here, but there's a couple of things I look for. So on their CTA, it usually will comment no evidence of right heart strain, or it will say something that indicates right heart strain, be it right ventricular dilation, a number of different things, interventricular septum flattening. There's a number of ways that they can see it depending on the image and the reader. If it seems like it might be submassive, but you don't have indications on the CTA, we sometimes get an echo that can be a little bit more clarifying. If the echo is normal, then I'm usually like, okay, it's not submassive. And then a massive PE is the ones you read about that are scary, right? So a number of these present with sudden death. And then if they don't, these are usually patients who have, you know, syncopal episodes or, you know, are just, they have an arrest, and they're usually the ones you see in the ICU with consideration of ECOS or TPA or what have you. So that's kind of the language that's used. So if you see a discharge summary that's a submassive PE and you've got this patient in clinic, that's what that means. Their right heart was compromised, but it wasn't so bad probably that they arrested or something like that. Other ways that you can determine right heart strain, so a troponin can sometimes help. A positive troponin usually indicates that it's at least a submassive clot. And that's kind of just a brief summary. Next slide. So let's start with one of our cases. So this is a 45-year-old female with metastatic breast cancer and new left lower extremity swelling. So being the astute clinician that you are, you say breast cancer, unilateral leg swelling. I paid attention in school. I'm getting a Doppler. Do you do a D-dimer? Probably not, right? Because even your basic, you know, mental checklist is going to tell you this patient is very high risk for a clot. So I wouldn't even bother. So you get a Doppler. It shows acute obstruction of the left lower extremity, femoral vein at the mid-distal thigh, popliteal vein, posterior tibial vein, 1 out of 2, and perineal vein. There's no evidence of DVT on the right side. Always order a bilateral PBL. You're going to want the baseline later. So this is what you get as a Doppler. Next slide. So how would you characterize this? Actually, can we go back one, or will that mess up full everywhere? Can you go back? So knowing that that's what I'm going to ask you, look at where this is located. Acute obstruction, left lower femoral vein, popliteal vein, posterior tibial vein, and perineal vein. Okay, now go forward.
All right, I love your clues.
Okay.
All right, how would you characterize this DVT? All right, we'll give them a few seconds.
Sure.
Looks like we're at 100% proximal. We got some other answers coming in. Maybe some people are switching their answers.
Oh, none of the above.
All right, how are they doing, Cassie?
Doing pretty good.
All right, do you want to tell them the answer or move on to the next?
Yeah, sure. If we're good. Yeah. So I would characterize this as a proximal DVT. So it has components of a distal DVT. So it has that posterior tibial vein, one of the two. It has, I think it was perineal vein involvement, but really the critical part here is that it extends into the femoral vein and the popliteal vein. And once it's kind of gotten to above the knee, we consider it proximal. It's not a superficial vein thrombosis because it doesn't involve the superficial veins. None of the above is an interesting choice. I think the only reason I would consider that is if you wanted to say it's both distal and proximal, but for categorization purposes, once it's at the popliteal or above, we consider it proximal. Next slide. So yeah, so it's, I just circled here so you can kind of visualize. So it includes the perineal, posterior tibial vein, popliteal, and the femoral vein. And so because you can see it extends knee or above, we consider it a proximal DVT. Next slide. So the next thing you're going to do is assess the risk factors, right? So every blood clot has a component of like a combination of component risk factors. So there's a lot of different things that can cause a DVT. If you remember the old triad, right, venous stasis, vascular trauma or injury, and hypercoagulability are the three kind of classic contributing factors. And then within each of those categories, there are several things. So if you just go through this list, so this is a great list of just general predisposing factors for VTE, for any kind of venous thromboembolism, and they vary in strength, right? So cancer patients, I've highlighted the ones that are more likely to pertain to cancer patients, the ones that you should have, you know, your spidey sense out for in your population. So major trauma, so any patient who's had a recent surgery is at risk for VTE. Blood transfusion to some extent, central lines, obviously, and catheters. Chemotherapy in and of itself, some more than others. Any kind of erythropoiesis stimulating agents. Hormone therapies, so in some of your, particularly your gyn-onc patients. Infections, pneumonias, anything that can cause systemic inflammation. Cancer is a hypercoagulable state, as I'm sure you all know. So that, you know, just by definition, having cancer puts you at higher risk. And then some of the weaker risk factors, so bed rest for more than 3 days or increasing age, you know, we're more likely to get clots the older we get. And if you're truly bedbound, not moving, we all know this is why we put people on prophy in the hospital. So these are all risk factors. And so what I do whenever I see a patient, what I would suggest you do is you say, okay, you've got this clot. What contributed to this? Was this just that you have cancer? Was that the only thing? Or were you in the hospital for a week and you had an infection and you had a line and you have cancer and you were on chemo and you got 5 blood transfusions? You know, there's usually more than one risk factor that contributes to a clot. Next slide. So this patient is currently receiving chemotherapy. She was recently admitted about 2 weeks ago for 3 days for neutropenic fever. No source was identified. She's not having recent blood transfusions and has not had surgery in 6 months. So I would list her risk factors as active malignancy because we know she has metastatic breast cancer, a recent hospitalization, which likely included some immobility, a recent infection, because she had a neutropenic fever. We assume there was an infection, though we did not find a source, and she's currently on chemotherapy. Particularly in cancer patients, but in all patients, really, you should also consider their risk factors for bleeding. So does she have metastatic disease to the brain? Would that put her at higher risk? That kind of thing. This patient has no real risk factors for bleeding. Next slide. So the treatment plan, these are kind of the contraindications you need to think about. And I highlighted the ones that will be more likely to come up with a cancer patient. So are they actively bleeding? I mean, obviously don't put somebody on blood thinner if they're actively bleeding in front of you. Certain indwelling neuraxial catheters, we're not going to get into that too much. If that's your clinical area, you should definitely be aware. And if it's not your clinical area and you come across it, please call neurosurgery. Clinically measurable, significant bleeding. It's a relative contraindication. It depends. It usually gives us pause, makes us think more about weighing these risks and benefits. Thrombocytopenia, we'll talk about more in a little bit, very specifically how to manage thrombocytopenia because that's going to come up in your cancer patients. And then some other, people with hemophilia, von Willebrand, that's not going to come up too often. Recent major operations is going to come up. High risk for falls is going to come up. So if you have someone who is, on some sort of CNS toxicity involving chemotherapeutic or just older, frailty, high risk for falls, that's definitely a consideration. And as I mentioned, CNS metastasis is something that we consider. Next slide. So what are you going to do? So the preferred, and so this is NCCN guidelines in the kind of orange, and then I just included the ASH guideline, which does pretty much agree with it in case, there's a lot of places you can get thrombosis guidelines, ASH, ASCO, NCCN, ISTH, a lot of them. They generally agree, and I'm trying to point out when they agree and when they don't, so you can make your own decisions on who you prefer to listen to. But generally speaking, patients without gastric lesions, we prefer a DOAC. So that's apixaban. Pay very, very close attention to the dosing of these DOACs, particularly if you're picking between apixaban and rivaroxaban. So apixaban, 10 milligrams orally twice daily for 7 days, and then 5 milligrams twice daily thereafter. Rivaroxaban also has an increased upfront dose, but it's 15 milligrams twice a day, and it's for 21 days, followed by 20 milligrams daily. Those are big mistakes I see all the time, is misdosing of the DOAC. So please pay attention if you choose to start your patient on one of those. We don't really use edoxaban very much in this country, so I won't speak to that. If you choose low molecular weight heparin, and there are reasons to do that, gastric lesions historically being one of them, we'll talk more about that as well, but dalteparin is usually what's picked. Here it's very hard to get, so most of my patients we end up putting on Lovenox, which you should all be quite familiar with. Sometimes we have to use unfractionated heparin. We really try to avoid warfarin due to a million reasons, but drug interactions being the primary one. But generally speaking, we are kind of moving towards starting these patients more and more on DOACs, whereas historically we maybe leaned more towards Lovenox. We've increasing comfort in DOACs in this patient population. Next slide. So just so it's in the back of your mind, are there specific considerations? So yes, the DOACs, you should be careful with chronic kidney disease or a recent AKI. 30 is a cutoff in GFR, creatinine clearance for that. Not to say that I never use it if someone's creatinine clearance is 25, but I look like how stable has it been, all that kind of stuff. And I sometimes check a drug level. So that's kind of, case by case. And then obviously, drug interactions are always going to be a problem in this patient population. And I usually check with the pharmacist if I have any question about chemotherapy drugs and their interactions. Low molecular weight heparin obviously also has to be, you have to consider renal function. Unfractionated heparin, please don't give it to someone with a history of HIT. That should go without saying. That's not specific to cancer. Fondaparinux, you have to be, basically all of these you have to be cautious with renal dysfunction. And then warfarin, as we know, has a ton of drug interactions and is difficult in this patient population. Not always impossible, but challenging. Next slide. So the treatment duration, so that's the hardest thing, I think. The vast majority of patients I see with a newly diagnosed clot with cancer are referred for a duration question. Someone has found the clot, decided it's a problem, started them on anticoagulation, but the question is, how do we stop it? The general rule is that you want to treat at least 3 months, often 6, and as long as they have active cancer. So specifically for ones that are not catheter associated, there wasn't some acute provocation, we tend to continue it. It can be very difficult to determine what is considered active cancer. One of the things that has bothered me / made me question how we determine active cancer is that if you look at trials on cancer-associated thrombosis, they typically have in their inclusion criteria anyone with a diagnosis of cancer within the past 2 years. I've never been able to get a good answer as to why we use that cutoff, but it stands to reason that you may have some residual hypercoagulability for an extended period of time after a cancer diagnosis. Now, I don't know any studies that actually look into that because no one really wants to find out by having someone, throw a PE shortly after getting over a cancer treatment, but it can be very, very hard. And also the patient's comfort with this continuing anticoagulation can be very difficult. Often they've just gone through a lot. They're in remission, but everything feels a little bit tenuous, scary. I typically continue anticoagulation until the patient is comfortable once they're in remission, but certainly not until at least they're in remission, and usually until I have at least one monitoring scan or whatever differs depending on the cancer. I usually wait even a little bit further. Next slide. All right, next case. So a 60-year-old male with rectal cancer, a new erythematous tender area with a palpable cord along the medial thigh. You send them for a Doppler, which demonstrates an acute superficial vein thrombosis involving the great saphenous vein 4 centimeters from the saphenofemoral junction. Next slide. How do you treat this superficial vein thrombosis? Do you give just a warm compress? Do you admit them for heparin? Do you give a full dose DOAC, like a Pixaban 5 milligrams twice a day? Do you give a low dose DOAC, like a Pixaban 2.5 milligrams twice a day? So I've given you the fact that this is superficial. It is not a DVT. So what do we do? Interesting.
I like the mixed responses we're getting. You're making people think, Leslie. Good work.
Well, these questions, if it makes anyone feel better, these are questions I ask myself. I mean, it's actually not a slam dunk answer. It's individualized. All right.
What do you think? How'd they do?
They did pretty well. So I would actually say C is correct, a full dose DOAC, but you could maybe get away with D. I have done D, depending on the patient and the circumstances. We'll take a look at what the guidelines are. Is everybody changing their answer? We'll take a look at what the guidelines are, but you wouldn't necessarily be wrong to go with D. That is actually the treatment paradigm in non-cancer patients, would be to use 2.5 milligrams twice a day. But let's look specifically at cancer patients. Let's look at the next slide. So first of all, is it superficial or deep, acute or chronic? Just because I trained with Dr. Mall and we never skip a step. So it is superficial, it is not deep. It is acute, we know that by symptoms, right? And probably based on the Doppler as well, but certainly based on symptoms. Next page. Okay, so assess his risk factors. So if you're trying to figure out, can I treat with full dose DOAC or do I need to go down to a half dose? There are a couple of things we should be thinking about, right? So he's receiving chemotherapy. He has not recently been hospitalized, has not had recent surgery, has a BMI of 40. So, and then he has a family history of PE in his father. So this is where we're trying to say, okay, what is his risk factor for a worsening thrombosis if I treat him for a shorter period of time or with a lower dose, right? It's not just that he has cancer. It's all the things that contribute. So he is on chemo. He has an active malignancy. He's obese, so BMI is 40. That's a risk factor. He has a strong family history, first degree relative with a PE. So he has 4 risk factors for venous thrombosis, and now he's had a superficial vein thrombosis. So what is his overall risk of VTE? I would say it's pretty high. Next slide. And then what are the risk factors for bleeding? So he has rectal cancer and a history of GI bleeding, so that's pretty significant. He's not on any antiplatelet medications. That would be insult to injury. Normal platelets, normal renal function, creatinine clearance is well within normal. His risks for bleeding, I would say, include primarily his GI malignancy and his history of GI bleeding. Next page. So I just want to make a note here, and I specifically included a patient with gastric or GI cancer to demonstrate this point. The NCCN guidelines do caution against the use of DOACs with GI malignancy. However, the Caravaggio trial does demonstrate that there are similar bleeding risks, at least with apixaban and dalteparin, including in patients with GI malignancies. So if you look at the major GI bleeding between the two arms of the trial, they are very similar. And so since this study was published in the New England Journal, we've really moved towards a little bit more comfort with DOACs, even in GI cancers. So if you were coming into this thinking, oh, I'm nervous to give a DOAC, I would be pretty comfortable giving a DOAC to this patient. Or I should say I'd be as comfortable as I would be giving dalteparin or Lovenox, right? His bleeding risk is probably not going to come from the fact that it's a oral medication. It's going to come from the fact that he has a history of GI bleeding and we're giving him an anticoagulant. So I just wanted to make that point because this is a question I get fairly often, a lot of anxiety about switching someone with a history of GI cancer to a DOAC. Next slide. So the guidelines for treatment duration, so this is kind of where we're going, right? So the guideline from NCCN is that you're going to do anticoagulation for at least 6 weeks if the superficial vein thrombosis is greater than 5 centimeters, extends above the knee, at least 3 months if it's within 3 centimeters of the SFJ, and then sometimes you can consider if it's like a smaller, less serious one and you're hesitant anticoagulating, you can repeat an ultrasound to make sure it's not extending. So the duration of treatment for this patient should be a minimum of 6 weeks because his superficial vein thrombosis does extend above the knee, but it is 4 centimeters from the SFJ. So I got you there, right? So if it were within the 3 centimeters, you would treat it like a DVT. And that actually is true even of non-cancer patients. If you have a superficial vein thrombosis that's within 3 centimeters of the SFJ, it's creeping into that area, you start to think about giving them full anticoagulation like you would with a DVT. The guidelines don't mandate long-term anticoagulation for this patient. However, given his constellation of risk factors, I would strongly consider it depending on how he tolerates anticoagulation, possibly at a lower dose after the initial treatment period. But overall, this situation really warrants a conversation. He's got bleeding risks. He got a lot of clotting risks. So depending on how long his treatment's going to last, what his prognosis is, how long he's thought to be at risk of recurrence, I would consider continuing even beyond that 6 weeks, depending on the overall situation. Next slide. All right, another case. 67-year-old female with diffuse large B-cell receiving chemotherapy presents with shortness of breath and pleuritic pain. Troponin is fortunately negative. The D-dimer is sky high. You get a CTA of the chest, acute PE involving bilateral lower lobe segmental and subsegmental pulmonary arteries. No CT evidence of right heart strain. So let's point at the important things in that. Oh, sorry. I'm going to try to help you out a little bit. So the troponin is negative. It's a bilateral lower lobe segmental and subsegmental, no evidence of right heart strain. Okay, next slide. Okay, so how would you categorize this? Would you say it's submassive because it involves bilateral lobes? Would you say it's massive because it involves both lobes? Would you say it's submassive because there's no evidence of right heart strain? Or would you say it's low risk because there's no evidence of right heart strain?
All right, looks like the majority is saying C.
Okay, so let's look at the next slide. So this would actually be a low risk PE. So I've got you again. So it's definitely acute, right? She came in with sudden new onset symptoms. There's no question there. We consider it low risk because there's no evidence of right heart strain. So remember, no evidence of right heart strain, low risk. If the troponin is negative and there's no evidence on echo or CT, we consider that low risk. If there's CT evidence or troponin or some evidence of right heart strain, that's submassive. And then that massive is really if there's hemodynamic instability. So, you know, it's a spectrum. But this person, it has not, at least that we know of, impacted her heart function. And so we consider it low risk. Next slide. So assess our risk factors, right? So they have diffuse large B cell, but she's not obese. Her BMI is 24. She has no family history of venous vein thrombosis or venous thrombosis. She's not on any hormone therapies. We're good. We do not have a ton of risk factors, just her active malignancy and her chemo. Her risk factors for bleeding, so she does get intermittent thrombocytopenia associated with all of her chemo cycles. And so that is very troublesome, right? And I get questions about this all the time. So let's learn how to deal with that problem. Next slide. So treatment for this episode would be the same as with a proximal DVT, right? So probably continued anticoagulation for as long as they're considered to have high risk for recurrence, which would be the time of their active malignancy. However, this patient, when you review her records and always look back at all their platelet values, is having platelet drops to the 20 to 70 range with each cycle. So how do you manage with that cyclical dropping of platelets? Next slide. So this is variable. It depends. So first of all, the NCCN does not recommend using DOACs in these patients because they're not as well studied. We do sometimes do it anyway. And so what I would say is where it says on here to drop to a half dose of Lovenox, we sometimes drop to a half dose of apixaban or rivaroxaban. If the patient is high risk, so within 1 month of the event, or they have a very strong history, you might consider transfusing platelets to 50,000, or in rare cases, an IVC filter. It is rare that we recommend an IVC filter. For patients that are a little bit lower risk for recurrence, so for her, she doesn't have a ton of risk factors. She's, you know, doesn't have, definitely wouldn't want to put a filter in her, and she's not someone that I would be worried in general of having a high clot extension or recurrence risk. You could consider holding with every drop in her platelets per this paradigm. I probably would not transfuse this person to 50. I would just hold as this comes up. And, you know, usually it's somewhat transient, right? So that the platelets drop and then they do recover. In certain malignancies, obviously that is not the case and it becomes a much, much trickier situation. But for the vast majority of patients receiving cytotoxic chemotherapy, you are going to have a dip and then it's going to come back up. And so you really, what you really need is someone who's paying very, very close attention to those platelets and telling the patient what to do. Next slide. Okay, and so the duration of treatment, so long-term, and I'm just bringing up the same, the ASCO and ASH guidelines. So 6 months, usually at least for a PE during cancer, and then if they're still thought to have active malignancy thereafter, we would consider continuing it. Next page. All right. So now you've got a 75-year-old male with metastatic lung cancer, with newly diagnosed left upper lobe and left lower lobe segmental pulmonary emboli, incidentally found on monitoring CT. Last prior CT was 3 months ago. No emboli were present. He is asymptomatic. Next slide. Do you treat this patient? Yes, I confidently start treatment. No, confidently, I don't start anything because this is incidental. Yes, apprehensively, I start treatment, maybe just for 3 months. No, apprehensively, I don't start treatment because he's asymptomatic. Where are you falling? Are you confident? Are you not confident? No one seems confident. Okay, there we go.
Where's the call Cassie option?
Yeah, right. Yeah. All right. Let's see. Okay, so first of all, it looks like most people start treatment. Some are half and half in terms of relative confidence. And then one person doesn't, and they're a little apprehensive about that. I'm happy to see these are all appropriate. I would say no, confidently I don't start anything is the absolute wrong answer. The rest of these are appropriate. So the answer is, next slide, you do treat it. Oh, I thought it was on the slide, but you do treat it. You're right. You will treat it incidentally found clot, and we'll talk about that in a second. So the CTA, just to define the clot real quick, there's no evidence of right heart strain. We didn't do a troponin. He was completely asymptomatic, didn't bother with an echo. It was incidentally found, no right heart strain on the CT. We would consider this a low risk PE. Next slide. So assesses risk factors. So he's 72. I think I said he was 75 before. He's in his 70s. Oops, I'm sorry. He's in his 70s. His BMI is 23. He's a non-smoker. He has no family history. He's been receiving chemo, has a port. He's been there for a year with no issues. No recent travel. He hasn't been hospitalized in over 6 months. No infection. So really, in the grand scheme of things, not a ton of risk factors. Active malignancy with a metastatic lung cancer and receiving chemotherapy are both risk factors, but those are pretty common, bread and butter among your cancer patients. Risk factors for bleeding, so his age starts to make me a little bit more nervous. The risk of bleeding on anticoagulation, especially for, when you're talking about cumulative risk, gets to be higher when you've got patients over about 65. So that would be my biggest hesitation. Next slide. So we've reviewed the drug options, DOACs, heparin, but for incidentally found, do you treat it all? And the answer is yes, and ASCO and ASH guidelines pretty much agree on this, although arguably with just that one little cross there. So the treatment is definitely to give at least the 3 to 6 months of anticoagulation. We don't have great evidence, but the outcomes seem to be similar in cancer patients. And so, your biggest concern is really that it's going to get worse. So you're going to treat it. And also, whatever conditions led them to get the PE at that time, also put them at risk of recurrence, right? Because we don't really, if the cancer was sufficient to cause a PE, even if right now it's incidentally found, you don't know that the next one is going to be asymptomatic too. Next slide. All right. And then this is, I think, our last case. So a 55-year-old female with uterine cancer, 3 days of worsening left upper arm swelling, pain, and tenderness. She has a PICC line in the left arm. Next slide. So you get Dopplers, confirm thrombosis, acute obstruction in the left brachial vein, axillary vein. Other veins are all fully compressible. Is this deep or superficial? Next slide. So it's a deep clot. But how fast are you pulling that PICC line? I could go either way. I'm definitely pulling that right now. I can just anticoagulate and leave the PICC line in, or I need more information to make that decision.
Got lots of answers flying in. While you guys are continuing to answer, I just want to send a friendly reminder out to you guys to have your questions ready. After this slide, you can start submitting questions through Poll Everywhere. Or keep Cassie on speed dial like I do. But think about your questions so we can talk with Cassie at the end. So how'd they do?
They did great. So, I need more information is like the clinical A+ answer. That's pretty much always right if it's given as a multiple choice option. So yes, I think you need a little bit more information to decide what to do with this PICC line. Next slide. So just to review real quick, the basilic and cephalic vein would be the superficial veins in the arm that we would see most often getting superficial vein thrombosis, but the brachial and axillary veins are deep veins. So this is a DVT. Next slide. So this patient's been receiving chemo for her uterine cancer. She had surgery 3 weeks ago as an outpatient. Her BMI is 32. She's not on any hormones, has not recently traveled, no family history of clot, not been on any recent hormones. It's a little repetitive, but you get the idea. So she does have active malignancy because she has a uterine cancer. She's on chemo, like most of these patients have been. She does have a surgery in the past couple of weeks, which is a risk factor. She has obesity, which is a risk factor, and a PICC line, which is a major risk factor, obviously. Fortunately, she doesn't have a lot of risk factors for bleeding, so we can be pretty confident we could anticoagulate her. Next slide. So treatment and duration. So the choice of drug, a DOAC or low molecular weight heparin would be fine. Probably would generally plan for a DOAC. The appropriate management of the PICC line really depends on what the PICC line is looking like and what the risks of anticoagulation are. So if the patient has no contraindications to anticoagulation, you can give anticoagulation for at least 3 months or as long as that device is in place. You can consider removing the catheter depending on if it's not functioning or it's no longer necessary. And then kind of what to do thereafter depends on their overall kind of course and trajectory. If they do have a contraindication to anticoagulation, then you do need to remove the catheter. And then, you know, you can kind of see if the area resolves. And if you're able to give anticoagulation, you can. If you can't, then you can do serial ultrasound to kind of monitor what happens after you pull the catheter. But generally speaking, we try to leave these in because oftentimes the patient needs a new one anyway, and we just have to go mucking around sticking in a new one, putting them at risk for yet another episode. So typically we try to leave them in and just anticoagulate through it. Next slide. All right, so these are just the take-home points. So the steps in managing a newly diagnosed DVT: define the clot. Is it superficial? Is it deep? Is it proximal? Is it distal? Is it a low risk PE? Is it massive, submassive? Assess the risks. What contributed to this happening? Was it just their cancer and chemo, or were they also bed-bound, post-op? Do they have a strong family history? And then determine your treatment. So a DOAC is generally acceptable. You could go with one of the low molecular weight heparins as well, and then determine duration, which is usually, as a rule of thumb, going to be the duration that they're considered to have active malignancy, but as we've reviewed, that can be quite nuanced. Anticoagulation with DOAC or low molecular weight heparin is preferred, but either is usually fine. You need to consider drug interactions, renal function. One thing I didn't talk about is cost with the DOACs. That can be a major problem. There are copay cards available. Definitely call a pharmacist if you're running into that problem. Line-associated DVT can often be managed without removing the access device. Anticoagulation has to be really closely managed in patients with thrombocytopenia to start and stop or lower the dose as needed. And incidentally found clots in cancer patients should generally be treated. So those are the major kind of take-home points I wanted to get through. And I think that's all I have. Oh, this is just a plug for the clinic. We are looking to expand our DVT walk-in clinic, which right now services some oncology for rapid appointments, but generally is available to the ED follow-up patients. And we're trying in the next year or two to expand this to outpatient clinics to be able to refer to our rapid follow-up clinic, including non-UNC affiliated offices. And that'll be great if we ever are able to get that off the ground. Even a local oncology, non-UNC affiliated place could send someone to us urgently for evaluation for a newly diagnosed DVT. So just a little plug for that. And then I think just questions, if anyone has questions.
Thank you, Cassie. This was really awesome and great. Some great tips and information you shared with us. I do tend to call and epic message you frequently for all of these things, so I always appreciate your knowledge on this stuff. So Cassie's a great resource. While questions are coming in, my quick question for you is talking about checking drug levels. I tried not to do this, but can you, with the DOACs, isn't there a special timing? If you just want a quick comment on the timing of
Yeah,
that? How we should do that?
honestly, I don't want this to come across wrong. I would refer to benign heme if you're talking about checking DOAC drug levels. I think that is too tricky to be doing. It's tricky for us, they do have to be timed. They have to be peak and trough timing of the different ones, and they're different depending on your goal. There's a prophylactic window versus a treatment dose window, and when one is appropriate or acceptable versus the other. It's tricky. So I would typically probably not, I guess you could, but I've never seen a non-benign heme person check those levels, and there's no data. So there's no studies that are going to say, oh, it's okay to do this, right? So it's all kind of experience and doing it all the time, which is why I would say I probably wouldn't do it.
Okay, great.
Yes.
I love that answer. Love that answer. All right.
One more reason to call me.
Yes, you're making that list longer, Cassie. When would you want to be consulted for a cancer patient with a clot?
So I think usually it depends. I think it depends on the comfort level. So, a lot of our heme-onc docs are, boarded in both heme and onc and feel confident. I think that I tend to see these patients when there's more nuance, when it's trickier. They have metastatic disease to the brain, and there's concern about major CNS bleeding. I've had patients referred because they have a history of CNS hemorrhage, and there's a lot of fear. I would say anytime that there's a high bleeding risk, I would consider a referral, because we might be able to tweak things in a way to try to mitigate that risk, and also because we heavily counsel patients on those risks. I don't think every cancer patient with a clot needs to be referred to us, but I think if there's some real clinical question about duration, dosage, or bleeding complications, I think those are very appropriate.
Yeah, and I have to say, Cassie, you've been always really great about, answering and even answering this question. Like, yeah, this is a little bit more complex, just send them, or no, you're good to go. So I just can't say enough about the resource you provide for these types of questions and unusual things. So what about re-imaging? Do it, don't do it? Is it a clinical course?
Excellent question that I did not get to. Don't just do it to do it. It's often not helpful. So always get a bilateral when you first get it. You want to get a good baseline bilaterally always. I can't tell you how often people come in and they had right leg symptoms. We do the right leg, and then we go to take them off and we do a bilateral for a baseline, and there's some chronic old thing in the left side and we have no idea, was it there 3 months ago? Was it not? Where did it come from? Did you fail your DOAC? Do I have to say this was a DOAC failure? You can never take apixaban again. Always get bilateral. We do not typically re-image unless we're concerned about clot extension in a patient who's on continuous anticoagulation. So if I diagnose you with a clot and I've put you on anticoagulation, unless your symptoms are not getting better or are getting significantly worse, I'm not routinely re-imaging. What I definitely do is re-image right before I take you off the anticoagulant. The reason for that is that chronic appearing clot that can show up, right? And so a significant number of patients are going to have chronic appearing changes in the vasculature. If you don't get that repeat image, and a year down the road, they're having signs and symptoms of post-thrombotic syndrome, which is fairly common, and they come in and they say, my leg hurts and is swollen, I have no way of knowing if I see, some changes in the vein, were those there at the end of your treatment course, and this is chronic and has remained unchanged, or did you reclot in the past year? So I don't routinely do it unless I'm concerned about clot extension in a patient with taking anticoagulation, but I absolutely do it, and you should do it whenever you take someone off a blood thinner, so that you have a baseline should symptoms or anything ever come up in the future, and you can compare. Preferably get a really good Doppler with a really good tech who can make very detailed comments, and who you may have access to later on should you need to compare the two studies. Great question.
Thank you. So can you speak to the ability to decrease the long-term dose? For example, Eliquis 5 milligrams to 2.5 milligrams 6 months after initiation of treatment in patients with active cancer. Is this worth doing, and in which patients?
It's a great question. It's a question that's a clinical question that's still being answered. So we have, I'm not sure if it's still enrolling. I want to say it's done. The EVE trial that UNC was a part of, looking at this exact question. So the bottom line is we have non-inferiority data in certain patient populations. I won't get into the details, but we do have data that shows a low-dose DOAC, which is a half dose, 2.5, as mentioned, of Eliquis or Apixaban versus 10 of rivaroxaban. We do have data in 2 trials that shows that dropping those doses in certain populations is non-inferior in terms of preventing recurrence compared to Lovenox or low molecular weight heparin. Or actually those studies might have been warfarin, now that I think about it. I want to say they're warfarin. In any case, the point is they're non-inferior. We feel comfortable using them in subsets of the population. We do not have evidence of that in the cancer population. So do I ever think about doing it? Absolutely. What do? I have a detailed conversation with the patient that, hey, studies in your specific population are ongoing. We have good evidence in other populations that this works and is not inferior. We haven't proven that in your exact case. The people I do this with are people with a higher risk of bleeding, people with a history of GI bleeding, people who are, at higher risk for falls, anything where I'm a little bit worried about bleeding, I consider dropping the dose. And it's always a risk-benefit shared decision-making conversation. And it will continue to be, I think, until those studies prove non-inferiority in the cancer population.
Our next question is, what about patients that elect hospice and are on a DOAC for a cancer-related DVT? When would you deprescribe?
That's a really difficult question that I think is kind of case by case. So if you have a patient who's ambulatory at home, who had an old DVT or PE that is more on it to prevent recurrence, and you're worried about falls, I would be considering taking them off of it. Whereas if you have a bed-bound hospice patient with a more recent episode, I would probably keep them on. I think it just depends. I don't think there's a quick answer to that.
Yeah, this has come up quite often in my world, and I like you said, it becomes a conversation with the patient and family, and I usually keep it going until they're not able to take it. People, unless they're having bleeding, right?
Yeah,
it's a case by case. I agree. I think you answered this question, Cassie, about decreasing the maintenance dose. So,
and the hospice question.
Yeah,
and I think until they can no longer tolerate PO, that's another good point. You probably don't want to be giving someone a shot and making them uncomfortable. So, yeah, I think that's, again, and you can, you can switch them to rivaroxaban, which is dosed daily to reduce pill burden. There's things you can do to try to make it, more doable, but it's definitely a conversation.
Yeah, for sure. I've got a final question for you. What's with all the insurance companies not wanting to pay for Eliquis anymore?
I don't know.
Okay.
I mean, I know
Just to make our life.
I get a message about it all the time.
Yeah.
Yeah, I don't know.
Yeah.
I don't know what there's if you look at, the National Blood Clot Alliance, I think, has a post about it that helps break it down. It's too much to get into here, but yes, it's a huge pain and it's a problem. And as you can imagine, I prescribe a lot of DOACs, and so I'm getting a lot of these messages. And we in Benign Heme have come up with kind of a way of managing this situation because it's, so impactful. But yeah, it's a problem. Hopefully we'll be remedied. I'm hopeful that it'll be better by 2023.
All right, a year. We have something.
That's my hope. Yes, that they will renegotiate and fix this for 2023. Yeah.
Great.
Yep.
All right. Well, thank you, Cassie. This was really informative. This was Really great. I appreciate your time tonight. Thank you everyone for attending. Thank you to the University Cancer Research Fund, to the Lineberger Comprehensive Cancer Center, and to our Cancer Network telehealth team. Without them, this would not be possible. They are behind the scenes making all of this work. So thank you to Tim Poe, Mary King, Benny Abure, John Powell, Oliver Marth, Jason Paler, and Andrew Dodson.